Well, welcome everyone. I'm Dr. Carmen Puliafito, and I'm here with my colleague, Charlie Wyckoff, to interview with us today the founding partner of the California Retina Consultants, Dr. Robert Avery. Bob, welcome to Retina Synthesis.
Thanks so much. Happy to be here.
You know a lot about gene therapy of macular neovascularization, diabetic retinopathy, and there's a lot going on. And Charlie and I would like to discuss with you your experiences and your thoughts about the future of this genetic approach to managing a chronic disease.
Well, it's an exciting topic. I'm happy to share what knowledge I have.
Can you just start with some basics and outline the biologic fundamental of gene therapy in the choroid and retina?
Well, there are two main classes of sort of gene therapy. One is replacement gene therapy, like the Luxturna, where we try to replace a deficient protein. And that's what most people probably think of with gene therapy. And that's not exactly what we're doing for macular degeneration or diabetic retinopathy, where we're using gene therapy to put in a gene to produce a therapeutic agent, such as anti-VEGF protein, and just have the body manufacture it like a bioreactor. And that's the technique that's being used in these treatments of AMD and diabetic retinopathy, which are not a single gene problem. And so it's distinctly different from most of the other gene replacement type therapies. Now, I find it very exciting because the promise would be to have a one treatment episode and be able to have your own body produce those anti-VEGF agents that we've been injecting more or less every month or two for years. And so the promise is really great if we can get it to work in a safe and effective fashion, that we could really dynamically alter the clinical experience we're so used to now, becoming injection automatons or robots. It would be really nice to treat someone once and not have to keep treating them thereafter. And fortunately, we've seen this in several of the patients in these trials. But it's injecting a gene, usually an adenovirus or associated adenovirus vector, that carries the genetic sequence for a molecule similar to Lucentis or Eylea, depending on the company, and inserts it into cells in the retina. It could be the RPE cells or the photoreceptor cells, especially if given subretinally, or ganglion cells or other cells within the eye when given intravitreally, for instance, iris epithelium, ciliary epithelium, or other cells. Intravitreal injection with most AAV viruses is blocked partially by the ILM, internal limiting membrane. So it tends to have the most uptake from the animal studies, at least, and other cells as well, more anteriorly. So the two different main approaches we have are intravitreal or subretinal, although a third method of suprachoroidal delivery is now being investigated too. But anyway, I ramble without any questions, but that's an overview of what we're looking at that's so exciting for our treatments of AMD and diabetic retinopathy.
So where are we today? Are we in phase 2 trials? Are we going to phase 2, 3? Where are we?
Yes, we're in phase 2 trials. We've sort of completed a phase 1, 2B trial with the anti-VEGF that's like Lucentis from the company REGENXBIO. And they're starting on other phase 2 trials. That was for macular degeneration. They're starting other phase 2 trials using the different delivery mechanism of suprachoroidal delivery, and also looking into a later stage trial in macular degeneration, going the subretinal way. And so Adverum, the other major competitor, shall we say, in this field, uses the intravitreal injections and produces a protein very similar to Eylea that is finished their phase 1/2 study, and they're sort of on a hold for diabetes. We can go into that in a minute, but they're going to reassess and come back in phase 2 just for macular degeneration based on some complications they noted. Some SUSARs or suspected, unexpected serious adverse reactions of hypotony and inflammation in 5 of 12 patients in the high dose arm of their diabetic study. So that trial, this just was announced a couple of weeks ago, but that trial is sort of on on hold right now in diabetes, and they're reassessing, going to do, instead of a phase 3 they had planned, they're going to go back and do a phase 2 with a lower dose in AMD and maybe lower doses than the low dose. They've not seen this side effect in any of the AMD patients, high or low dose, and they did not see this side effect in any of the low dose diabetic patients, but they did have 3 patients that were very severely hypotenuse, I believe, required surgery, and I think 5 out of 12 had some hypotony and inflammation that was beyond what was expected. We knew that viral vector, the AAV2, was a little more inflammatory, shall we say. It was sort of known to have a little bit of inflammation. So they initially started their trials using a sort of steroids protectively, systemic initially, and they realized that sort of controlled it. The inflammation came a little late, and so they changed to a topical strong agent such as Durezol, because they knew that there was an inflammatory potential with the intravitreal AAV2 vector. But late, roughly 6 months or so into the trial, they started seeing these cases of hypotony and associated with inflammation that we don't know the exact etiology, but it was fairly severe. And they've sort of unmasked the trial, and they're treating those patients aggressively with steroids and immunomodulating agents, and hopefully we'll be able to have some recovery of vision and pressure in these eyes.
How about what were the results like in the intravitreal treatment of neovascular macular degeneration?
They were excellent. I mean, there was the OPTIC trial is the name of it, and they had fantastic, in my opinion, fantastic results prior to this unexpected adverse event or 2 or 3. They had a reduction in the injection frequency of 85% in general, but they had many patients that seemed to be one and done, and with a simple intravitreal injection, not nearly as invasive, shall we say, as a subretinal delivery, which requires a trip to the operating room, a vitrectomy, air bubble, which is the way the competitor, the Regenx AAV8 vector is given. And so it seemed to be, until they had this hiccup here, that this was likely to be a very attractive option, if the future studies held the way the initial studies were looking. They did have some inflammatory reaction. It was mild, responsive to topical drops, and they stopped using the systemic steroids because the inflammation didn't really pop up until they stopped the steroids systemically, and it was fairly well controlled in general with a topical drop. And so I think the AMD patients sort of may have lulled us into, or them into, a state of less concern about the inflammation. And so when they went to diabetes, which is a little bit more of an inflammatory disease, and these are younger patients too, when they went to diabetes and noticed this, we don't know yet if more advanced or more stronger immunomodulating agents earlier on may have modified this outcome. But that's the way phase 1s go. You learn as you go, unfortunately. And this is an unexpected turn of events that sort of put a hold on that treatment for diabetes. But the AMD treatment is still alive and kicking, and they're going to use the low dose, which had a very good outcome. As I said, they had excellent results with both the high and the low dose, and they were already thinking about even lower doses for AMD. I mean, it seemed to be the protein levels they measured in a few patients were extremely high in the aqueous, maybe partially because it's probably made more in the anterior part of the eye. I think from the animal studies, the uptake seems to be, the transduction seems to be in the iris and the ciliary epithelium a lot more so than in the subretinal delivery used in the Regenx trials. And so the aqueous levels may have been a little higher because it was being made more anteriorly, but the levels were excellent. And that corresponded to the improvement we saw, which was dramatic. I mean, marked reduction in injection need and just drying up a fluid that had been there and for many, many months with many, many previous treatments. Both agents seem to have great promise in that regard. And it was very exciting. I'm disappointed to see this turn of events, but hopefully it won't stop the AMD indication. And we're still working. What is it? Sorry?
What are the plans for AMD with Adverum?
I believe that they've announced that there's a phase 2 study that's going to be done with it, and they're going to look at the lowest dose only and lower doses they mentioned. And, there are several reasons we might expect this to still be safe. One, we've not seen any sign of this in the AMD patients at the low or the high dose. Two, the diabetes has a little bit more of an inflammatory role, shall we say, than in AMD. And three, in my opinion, the patient age is different. The older you are, probably the less transduction you get in general. Young monkeys would make like 10 times as much of a protein as we'd see in the humans trials. And I think age has something to do with the transduction efficacy. And I think, there's a possibility that the younger people just at the higher dose may have had more uptake in the ciliary body or ciliary epithelium, and it may have just been cranking out more Eylea than needed, and maybe not enough of the proteins in the pump that make the aqueous. And so it could have had something to do with younger people with the higher dose just transducing more and being too effective and overriding the usual function of the ciliary epithelium. That's my personal hypothesis, but that's just me. That's not been, I've never heard that from anyone or read that anywhere, but that I do know from REGENX bio results that I've had lots of patients have a pigmentary change around the same time, about 6 months out, where there's pigmentary change in the retina, especially inferiorly, where the vector would drip down after the gas exchange in the operating room. And where you had this high dose of the vector inferiorly, it tended to create some pigmentary modeling over 6 months or more. And I could assume that there's just an extensive transduction there. We're making a lot of protein in those patients, and they did exceedingly well. But the time frame seemed to be the same in a way with these Adverum eyes. It wasn't immediately after the vector was there, and so it was injected. And one might think that if it's due to the vector itself, you might have had more of the inflammation and such, earlier on than 5-6 months into it. So to me, it makes me concerned that it has something to do with what the vector is doing, and maybe it's just overwhelming the epithelial cells of the ciliary body, and that may be why the hypotony is there. But I'm not speaking for the company. I'm not part of the company or trial, so that's just a hypothesis on my part. But anyway, REGENX, I did mention this pigmentary change in REGENX, and it's a similar side effect that was unexpected. I had one patient that did have some of the pigmentary modeling in the macula, and right before their 1-year visit, they had a drop in vision due to it. So we reported that as another unexpected serious adverse reaction. And so these things do occur, and I think we can avoid the pigment changes in REGENX bio by having the bleb made inferiorly. We were usually putting them outside the superior temporal arcade, and one of the thoughts was that then the medicine, shall we say, the vector would spread across the whole retina as the bubble, went away and was pushed away. But I don't think that's a good idea now. I think at the higher doses, it's better to have that vector outside the arcades inferiorly, and maybe rotate the patient after the surgery and have it, drip off to the side where it would be in the far periphery and unlikely to have any visually significant effects, but still be able to make the protein. This is the beauty of the bioreactor type of gene therapy that I'm talking about, because where the medicine is made isn't that relevant. Whereas with Luxturna, you want to replace the gene in the fovea where you have your good vision. So we could make the protein in the iris, or we could make it in the far peripheral retina, and it could still be effective. A little different from the other type of gene therapy.
And Bob, what do you think those pigmentary changes are in the REGENX bio program that you've beautifully described here and previously? You think there are RPE cells that are turning that are changing their phenotype slightly and becoming clumped, or what are we seeing, do you think?
Yes, I think that's a fair description. I think there's both clumping of the pigment cells as well as atrophy adjacent. It's sort of a combination of hypertrophy of these cells with some atrophy repeated over and over. And so when you do an OCT through this area, there's a term I've coined for it. I call it the barcode sign, because it looks a lot like a barcode that you see in the grocery store on an item, because it's really dense and really, light, and really dense and light at differing, widths. And it's very, very prominent. When you see it, you'll know it. But I think it's probably these cells manufacturing a lot of the protein. We've measured really excellent levels in the aqueous, each of these patients in that trial had aqueous levels taken frequently. And the patients in the higher cohorts, 4 and 5, had the highest dose given, had the most pigment changes, and had the most protein, and had the best response. The first couple of doses were used were, I don't want to say homeopathic, but they were not effective. They didn't really produce much protein at all, and they didn't really affect the injection frequency. They were just testing the water to get the right dose, which I think we achieved when we got up to levels 4 and 5, the cohort levels there. Cohort 3 was intermediary. We had a good response. It was an easier cohort to treat because they didn't have the same, it wasn't as severe of disease as the others. But it had an excellent response. And so somewhere in that range, we had an escalating dose range of the 5 cohorts. And I think they have found a good dose. This could be what Adverum needs to do now, is just find the right dose. It may be that only too high of a dose will produce too much ciliary body atrophy. This is all hypothetical, but maybe a lower dose, which they're going to explore, is going to do the trick without the side effects. And, it's always a risk benefit analysis. And I certainly hope we can find the right dose for both of these agents. But I think we have for Regenx, with the caveat that we've learned what I hope will be effective by tilting the head, doing the inferior blebs, keeping the actual medicine away from the fovea in that first 24 hours while it's resorbing. I think we could use higher doses. And, we've accepted PRP for a long time, damaging a little peripheral retina to save the central retina. I'm not saying this is as damaging as PRP, but, and it would be a much smaller area, but I think it's certainly acceptable in my book. I've seen patients just love this treatment. I mean, I had injected them for 50 times over years and then not needing a single injection after a year or two after the treatment. And those people are ecstatic. And I just, I think there's a lot of promise to these techniques. And these are, we're still early in the scheme of things. I mean, think of it, there's only 30 or 40 patients in each of these, groups that we're talking about here. And that's baby steps in the development of something like this. So it's unfortunate that we've had some unexpected outcomes, but I think it doesn't mean we need to give up. We just need to figure out the best, safest way to deliver it without, causing any visual loss, if anything's avoidable, because the benefit is huge. And I've got patients that just, during COVID, they did not want to come back. I mean, we had to follow them monthly, and they were like, "But you cured me. Why should I come in? I don't want to come in. It's COVID. I haven't needed an injection for a year. Why do I need to come back next month, this month? I'm fine." They were arguing, these are the same patients who would, fight to come in because I knew what the injections would do for them. A lot of our COVID patients didn't care about COVID. They knew if they didn't get an injection that month, they were going to go blind or lose vision because they'd experienced it with other delays. And so, it was a nice sort of reversal of the roles there. And so the people that benefit from this and can just never have another injection, at least for years, really love it, as you would expect. So it's an interesting thing, but very exciting.
You describe it perfectly. It certainly is an exciting time, and I'm glad that you're one of the leaders in the space, Bob.
Well, what about the suprachoroidal delivery approach?
Well,
there's been lots of lots of interest in that, and REGENXBIO has shifted a lot of its future thinking toward that approach. Can you comment about that?
Sure. The suprachoroidal delivery, it uses the same needle that Clearsight has used for triamcinolone, and it is an in-office procedure with a needle that is placed through the sclera into the suprachoroidal space, and they're able to monitor the injection with a thermal camera, which really helps a lot to validity, it gives validity to where it went, and the spread you can see is, I think, really helpful in knowing, because it's sort of you can't see it being in the space for when you're doing the injection, and so it's nice to see the thermal spread and know that it's where it's supposed to be, which it is almost all the time. But I think that this is the option of having an in-office procedure, which may or may not have the same efficacy of the subretinal. I tend to think it won't be as good. The animal data that Peter Campachero did using GFAP looked very good, and there was really good uptake. But I'm not so sure when they shipped it to REGENX's molecule, the Lucentis-like molecule, the uptake was quite as prominent in the retina. And only the study will really answer that question. The beauty of it, though, is that even if it gets a lower dose to the vitreous cavity, to the retina, that may be acceptable for some of the indications it's being used for. For instance, diabetes. I had arguments with the team at REGENX about their trial for vitrectomy with gas bubble and subretinal injection for diabetes, because I told them that just doing the vitrectomy and is going to alter the course of diabetic retinopathy, because you take off the hyaloid, you have better oxygenation, there's no scaffold there. Just doing the vitrectomy is going to alter the progression of diabetic retinopathy. And there's a whole host of people that think that maybe vitrectomy should be used earlier in a subset of patients with severe diabetes, just because you can cure the proliferative part of it, by doing it early. That being said, the cataract progression was going to be a problem, especially since most of these patients with early diabetic retinopathy were phakic and younger. And so the trial design was very hard when we were having to go subretinal. And I was so happy that they got access to the suprachoroidal needle, because that allows us to deliver the drug without violating the vitreous, without really changing the dynamics in there that could affect the diabetic retinopathy progression, and also without affecting the lens status, because we know vitrectomy can induce cataract over time. So I was really excited to have this option, and it's really exciting. Results aren't out yet. They'll be presented soon. This fall, we'll have a formal presentation, but we'll be hearing more about it before that. But it's really exciting that in this disease, we may not need as much anti-VEGF as we need for a wet AMD patient to alter the progression of diabetes, and so the retinopathy score. And that would be a game changer too. I mean, if we could sort of stop or slow dramatically the progression with a single in-office injection, that's a big step towards helping a lot of people. Whether it has the power to deliver enough anti-VEGF to stop the wet AMD in those recalcitrant patients that we've been treating in the study so far remains to be seen. We'll find that out. That trial is ongoing as well. They're doing suprachoroidal for wet AMD too. There's a phase 2. And so we'll see. We will see. But I don't think that from the animal studies, I don't think it's going to be quite as potent. I have no idea in the clinical yet. It's too early to say. There's also a theoretical advantage for the subretinal delivery about the immunoprivileged area there. I mean, the eyeball is great for gene therapy because it's relatively immunoprivileged. In the subretinal space, more so than the vitreous space, or much more so than the suprachoroidal delivery, because that's going to be flushed into the bloodstream as you inject it. And so, there's some other components that are maybe disadvantages to the suprachoroidal. It may not get as much drug to where you need it. It may, but it may not. It may have more interaction with the systemic circulation, more of a concern for immunogenicity. but it is stunning the neutralizing antibody status from the subretinal REGENX study really showed, if anything, an inverse correlation. Certainly not a correlation with if you had antibodies to the AAV, it didn't affect your protein production, even the opposite. You had more protein production. So it's nice to see that the pre-existing neutralizing antibody level really wasn't that relevant for the subretinal. But that may not be the case in the suprachoroidal because it's not really as immunoprivileged. So a lot of uncertainties, but it's great that it's in humans because that's where you're going to figure it out. You're not, some of these questions you just can't answer in an animal sufficiently. And it seems to be safe enough to be in humans, and it seems to be something that has a lot of promise. Certainly it would be nice to avoid the vitrectomy, but I certainly think having had a bunch of people in the REGENX subretinal trial that are so happy that, even if it doesn't work, we have something that does. And I'd be very happy to do this for people who have a high treatment burden.
So is REGENX Bio planning a phase 3 trial using the subretinal approach?
No, not well. They may be planning it beyond us right now. They're just doing the phase 2s right now, and they haven't even reported any evidence of efficacy yet. It seems to be safe enough, but I mean, they haven't really reported anything on it yet. I think it's a little early for them to plan it in any extensive detail, but I guess of course they're thinking about it. But I don't see it on the horizon because the phase 2 is just got going not that long ago. So eventually, yes, I hope. I certainly hope so.
Well, Charlie, do you have any final questions?
Great comments, Bob. I guess the last question I would ask you is, we've learned a lot from REGENX Bio and Adverum publicly, and we'll continue to see those data sets unfold. It's fascinating how many additional players there are in this sort of gene therapy space for common diseases, right? You have the Humira product now that Janssen has, you have Gyroscope moving into this space, and many others sort of thinking about it. It'll be interesting to see how the field unfolds as we continue to learn from REGENX Bio and Adverum. I don't know if you have any thoughts about sort of applications from what we've learned so far with the anti-VEGF gene therapies towards these other products, the two I mentioned, of course, being in dry AMD with very different products themselves.
Well, I thank you for the opportunity to talk a little bit about the dry end of things. I mean, certainly the Humira with the MAC inhibitor complex, inhibiting the MAC complex is really interesting. It's like the final stage in the complement cascade, and we'll just have to see. The data are fairly small so far, but that's an interesting approach. And we will be having results from the injected complement inhibitors. I think Apellis is supposed to report this quarter, and then Iveric probably a year later. But we'll see if it works. We were all disappointed Genentech's did not work, the lampalizumab, but things look better for these other ones. And it may just be the further down the cascade you go, the more the chance it'll work. But we'll see. But Gyroscope is working on complement factor I. And I really think that one thing I'd like to comment about them most is their delivery system. They have a very interesting way of putting a cannula through a sclerotomy and into the subretinal space, again, without the vitrectomy. And it is more of a procedure than a suprachoroidal injection. It's not something I would be doing in the office, but it is another way of getting into the subretinal space in an efficient way and without violating, the lens status of the vitrectomy, which would induce cataract or something. And so it has a lot of applications in other areas as well. But it's really exciting the way they're doing their trials. They're looking at people who have just different stages of atrophic AMD, different defects or no defects in the complement, or especially the factor I cascade. And so I think they're doing it in a very, very reasonable approach. They're going at multiple levels to see where this might work the best. And unfortunately, dry AMD is a slower disease process to monitor, and it takes time but they're on the right track. And I think both of these approaches have a lot of promise. We'll know more if we can get a complement inhibitor to work in a phase 3, which may happen this quarter. Then it increases my level of excitement. But I'm already excited about it because it would certainly be nice to stop that disease too with a single procedure.
I agree. Exciting time.
Thanks a lot, Bob, for joining us on Retina Synthesis. This has been a fantastic discussion, and we hope to get back with you in another 6 to 12 months and see whether or not your predictions have come forth.
It'll still be exciting. Hopefully it won't be depressing. I'm sure it'll be very exciting in another year. So thanks very much. I appreciate the opportunity, and thank you.